Welcome to Social Work Live at the Columbia School of Social Work. My name is Michael Friedman. I teach health policy and mental health policy here. Each week we interview a member of our community to discuss the latest in social work practice. We'll talk for about 15 minutes together and then we will take questions. If you have a question, please enter it into the comment section of the screen that you're looking at. This week, I'm very happy to say we're talking with Carmela Alcántara, who is quite an eminent researcher in issues related to health disparities and with a particular interest in sleep and what that contributes to health problems and health disparities. And our title today is Sleep Well, Your Health May Depend on It. So I guess the first question is, what does it mean not to sleep well?
I think, so that's an excellent question, Michael. One, because we've actually been thinking about sleep health more broadly. And so it's not just about, are you not getting enough sleep, but it's also about the quality of your sleep. And it's also about the timing of your sleep when you're actually sleeping, and also how satisfied you are with your sleep and how consolidated of sleep are you getting. So it's not, sometimes when people think about are you sleeping well, you go back to what you heard in your childhood, which is are you sleeping 8 hours, 8 hours, right? That sort of was what I grew up thinking was the recommended amount of sleep. And so now we've sort of shifted towards just emphasizing one dimension of sleep and actually thinking about it as a multidimensional construct, that it's not just how many hours of sleep you're getting, but the quality of the sleep that you're getting, how satisfied you are with your sleep.
So part of it is how satisfied you are with it. So there could be people who sleep 4 hours a night and feel wonderful about it, get up the next day, and they're just terrific, and other people who don't feel comfortable unless they've had 9 or 10 hours.
So I think, so there are individual differences. So I think, that's one thing we definitely could agree to. There are recommendations, though. So I would argue that the person who's getting less than 4 hours, then the prevalence of people who actually are only getting 4 hours of sleep and are functioning at their best and under optimal conditions is actually quite low.
They used to say that about John Kennedy, that he only slept 4 hours a night and then took cat naps. I've always thought I could have been a genius if I didn't need sleep, but maybe not.
No, when I sort of talk and give community health lectures, one of the main things that I do is to really talk about, well, why is it that people don't sleep as much as they should, and what are the factors that contribute to that? And I often pause to explain how there's actually cultural frames that contribute to why we think that sleep is either a luxury or a necessity. And if you think sleep is a luxury, then, it's something that in this 24-hour society is optional, and actually the sleep loss is a status symbol, right? It becomes something that you're, not you per se, but that people are sort of boasting about. I was able to do so much on only 2 hours of sleep. I was able to do so much and I didn't even need sleep. And that's problematic, actually, when given everything that we know about the ways in which sleep contributes to the restoration of your mind, the restoration of your body. And so it's, that's one cultural frame that contributes towards feeling like it's optional.
So this cultural feature is really interesting. Is there also a male-female difference with that, or not?
That's interesting. In terms of the cultural beliefs about whether it's optional.
Well, is it sort of macho to get by on 4 hours sleep and to brag about it? But maybe, I don't know if women have the same attitude who are ambitious?
That's a great empirical question. I actually don't think that we've, from the data that I know, that's sort of been examined in a really systematic way. And there probably, I think, would be country by country differences in that.
But you are saying cross-culturally it's better to get a good amount of sleep. A good amount of sleep may be variable from person to person, but not enormously variable.
Right.
What about the duration of an episode of sleeping? I'm not asking this question but some people will sleep for a couple of hours and then wake up and then sleep another couple of hours later on and so forth. Is that kind of disrupted sleep something you regard as poor sleep, or?
So that's actually getting a little bit to sort of the sleep efficiency. So I had mentioned how there's these different dimensions. There's a duration, there's that satisfaction or quality that's more subjective. There's the efficiency, which really would include things like these sleep disruptions or aspects of fragmented sleep, and then there's the timing of when when you're sleeping.
Right.
And so you're sort of getting at this efficiency part of the sleep by the aspect of sleep that if someone is sort of getting up multiple times at night, then they're not really experiencing this consolidated type of sleep.
Do you find many people who are productive during the periods that they're not sleeping? So they sleep 3-4 hours, they get up, they're productive for a period of time, and then they go back to sleep?
I think it's interesting. I was talking with a colleague the other day, and she had mentioned to me how, and I'm not sure if it was in the 90s, but it was something that was popularized, where it was, sleep 4-hour chunk, then you sort of get up, do something, and then sleep another chunk in terms of breaking that up. I think right now the recommendation is actually, by the American Academy of Sleep Medicine, by the Sleep Research Society, is that in order for optimal health, the recommendation is to sleep 7 hours or more. And it's a consolidated
at one
sleep
time.
In one
Go to
chunk,
sleep and stay asleep for 7 hours.
One block. There's individual differences.
Right.
It's sort of a goal, like what you're striving for on a daily basis. And so, I think to the extent that people can do that consistently is better than not doing it consistently.
So let's suppose that doesn't happen.
Yeah.
So what happens to people like me, for example, who don't achieve that goal? What's the impact on our physical health, our mental health?
Yeah, and so there's one thing if it's intermittent, right? It happens only occasionally,
Right.
and then you might sort of be making up for some of these sleep deficits in subsequent nights. And it's another thing if it's chronic, right? And so that's where I think we see the most consistent links to adverse or poor health outcomes, when it's this more chronic type of a more regular pattern of poor sleep, of sleeping less than 7 hours, 6 hours, of having poor quality sleep. That's where we tend to see the increased risk of depression, increased risk of obesity, of diabetes, of cancer, of mortality. It's when it's sort of consistent, repeated, chronic patterns of sleeping for less than 6 hours or so.
So that's interesting. You're saying that people who don't sleep well would be more likely to have diabetes, with obesity as the intermediary, or just if you control for obesity, is that still true?
Well, so some of the mechanistic work to see how does sleep affect diet, for example, has actually found that when you, and these are lab-based studies where they will take people in, they sleep, they deprive them of their sleep on purpose.
Right.
So come in and they restrict them from falling asleep. It's tough to do, but people actually are willing.
I hope they have a refrigerator
Yeah.
nearby so they can get up and eat.
So that's sort of exactly my point. So what they tend to see in these studies is that people who are deprived of their sleep, so they're sleeping only 4 hours, actually this loss of sleep affects appetite regulating hormones that lead to actually you feeling hungrier. And so what tends to happen is that they'll tend to eat more the next day. And so it's sort of this cycle. It affects, how, and I mean, I can think about it. I'm more likely to have the donut or the cookie or the brownie.
Well, you look like you can afford to have the donut. As you can tell, I have too many donuts in the middle of the night.
How well are you sleeping? Huh?
Not very well.
Exactly.
You also mentioned that there's a connection between lack of sleep and depression.
Yeah.
And do you see that as something that goes in one direction or a reciprocal direction?
That's an excellent question. There's actually been a lot of great work, and there's some studies that I'm doing here that's testing just that, these bi-directional relationships between sleep and negative mood, depressed mood, anxious mood, and stress, and actually finding that there is, in some studies, there is evidence of reverse direction of the bidirectional relationships, and other studies actually where sleep on one night is influencing how you're appraising, perceiving, experiencing your environment the next day. And so it's related, if you're sleeping poorly or less on one specific night, that's affecting your stress rating the next day. So you're more likely to report higher stress during the following day, worse mood, so more anxiety, more depression.
And then worse sleep.
Yeah, and then worse sleep the following day.
So it's another one of these vicious cycles of typical of depression.
Yeah.
Depressed, you're less active, you're more depressed, less contact.
Right.
Same sort of thing that's taking place.
But there's been some studies actually to show that sort of it's going first from sleep to that.
First from sleep to
Yeah.
that. That's interesting.
It's super interesting, because even in other work that I've done, it's been sort of looking at the relationship between stress to sleep, because intuitively it makes sense, right? You're up, you're worrying, it's affecting how you sleep the next day. But there's been some other work that's, I think, presenting some new data to suggest it's actually going from sleep, that your sleep quality is shaping how you're viewing and experiencing the world the next day.
That's really fascinating. I mean, many of us who sleep badly experience ruminations at night. Which is just a fancy way of saying we worry about a lot of stuff. It's on our minds. It just keeps going.
And in fact, some of the treatments are specifically, are to help people deal with that rumination at night. Some of the treatments for some of these common sleep problems.
So why don't we move to talking about the treatments? There are ways to try to deal with problems of sleeping. And
Sure. And there's the treatments are different depending on the sleep disorder. The most common sleep disorder is insomnia, as we were talking about, sort of that clinical syndrome of insomnia where you're having, difficulty falling asleep, staying asleep, and waking up early morning awakenings accompanied with distress. That we actually, as mental health, as I think a field of sort of mental health professionals, have contributed a lot towards the gold standard of care for treating insomnia, and that's cognitive behavioral therapy for insomnia. And we know that actually works much better than just medication alone in the long term for improving and reducing insomnia.
But let's talk for a minute about medications. Obviously, there are a lot of sleep medications on the market, some prescribed, some not prescribed. Ambien, I guess, has gotten a bit of a bad reputation lately. Which you might want to talk about, but there are all these other drugs that you can just walk into the store and buy. They're pain relievers that have I forget what it's added to them to make them
cause drowsiness, antihistamine.
Yeah,
or something.
antihistamines.
Yeah.
So what do you think of those?
Well, they're sort of, in my opinion, they're kind of short-term fix. The issue I think people who suffer from insomnia also experience a sense of despair, so they sort of want, I think they're highly incented to sort of seek treatment because they want to feel better. It's like, get this thing, help me feel better. And these medications, if they're over-the-counter or prescribed, they tend to be short-term fixes. And what we know from the research, from the literature, is that cognitive behavioral therapy is the best treatment. It's the gold standard that will produce long-term benefits. So they follow people over time, and in 2 years' time, let's say they took medication and compared to cognitive behavioral therapy for insomnia, those that took the CBTI
The typical recommendation to primary care physicians, as I understand it, is to try to engage their patients in what's known as sleep hygiene.
It's CBTI now.
It's now CBTI?
It's now CBTI.
There are primary care physicians who know how to do CBT?
They don't know how to do CBTI, so it's an implementation issue. Because we have a treatment that actually works really well, but we're having difficulty, I think, getting it to the people who need it. But literally, the American Academy, I think, of is it family physicians? Their recommendation now is for CBTI for insomnia, which was a big change.
So there are elements of CBTI, as I understand it, which is not very well, that are similar to sleep hygiene.
Yes.
When you go to bed, taking naps, a number of different recommendations. Are there differences between the regular recommendations of sleep hygiene and CBTI?
I think the big piece, so the behavioral aspects are all there, changing the sleep environment. You sort of engage in sleep restriction because you're helping people get consolidated, good quality sleep and get the experience of good
So what is
quality
sleep restriction?
So it's when you're not necessarily saying go to bed and sleep 7 hours. You actually might be working with them to figure out what their optimal sleep timing might be. So it might be recommended, actually, we're going to recommend to you to only get 4 hours of sleep this night, and that you're going to go to bed at 1 a.m., 2 a.m., and wake up at 6. But the goal is to get you to experience what good quality consolidated sleep is. And sort of you're working with the patient to figure out what those parameters are in terms of the timing.
And a lot of people who work on sleep say don't take naps.
Yeah. That's true.
I'm an old man. You can't tell me not to take naps. I couldn't survive a day without taking naps. Or maybe I'm wrong about maybe I would actually sleep at night if I didn't take naps.
I actually think that's, Michael, you might be treating yourself here, but, that is the recommendation, is that you're helping people, you're trying to retrain your body such that you're building up your sleep drive so that you're the sleepiest by the time that it's time to go to bed. And so one way to do that is obviously to limit, reduce, eliminate naps altogether, but it is a conversation between, the provider and the client. And the
So does CBTI include a variety of things related to cognition and what your beliefs are, and the way that we treat depression with CBT?
Yep.
Those elements are also included in this, so it's not just change your behavior with regard to sleep, it's also getting into some discussions of some kind about.
Yes, you're absolutely right. So another big piece is about helping people change their maladaptive beliefs about their sleep. And so, people with insomnia sometimes they might really obsess about their sleep and feel like, I actually won't be able to function the next day. But you use, cognitive behavioral therapy, sort of cognitive reframing principles to help them think, well, actually, how many times have you functioned actually quite well on poor sleep, to sort of help them get through the treatment and to sort of talk back to some of these negative thoughts that might actually lead to more vigilance about their sleep.
Is it almost exclusively behaviorally focused, or could there also be a discussion about you're depressed, your ruminations are filled with fear?
Yeah.
That would be part of
absolutely.
the conversation that takes place in doing CBTI.
Yeah, I think there's a lot of cognitive reframing and restructuring about, these beliefs concerning your sleep.
Right.
And sort of there's a lot of also psychoeducation in working with the patient to understand, well, what factors actually contributed to the initiation of your sleep, what factors are contributing to the maintenance of your sleep, what's sort of precipitating and perpetuating your insomnia issues. So there's a lot of psychoeducation and cognitive and behavioral work.
So we've already said that physicians who are dealing with sleep problems ought to be doing CBTI, but probably aren't.
Right, or that they have or that we had better systems to refer people or more qualified providers to treat people. That's the big issue.
So let's talk about that.
Yeah.
I would assume that there aren't a lot of qualified providers, even in New York City.
You're right. And actually, one of my interests, like you mentioned in the beginning, is focused on health disparities and mental health care disparities as well. And I'm really interested in, and I'm doing work focused on the Latinx community and specifically Spanish speakers. And so there's this huge, big supply and demand issue, and that the demand for providers who are trained in CBTI is actually, the need for treatments is actually quite high, but the supply is low. And this is compounded among those who need services in Spanish. And actually some of the work that we're doing now is to adapt a digital version, an e-health version of cognitive behavioral therapy for insomnia for Spanish speakers, Spanish-speaking.
So first you have to explain to me what a digital version of CBTI is, since I'm envisioning a relationship between a therapist and somebody getting therapy. But digitalized, what is that?
Yeah, so it sort of has shifted. It's tried to create an analog version of the one-on-one relationship, but in a self-guided, version that's delivered either online or, online, and it can be on your smartphone or via the internet. And so that's the digital health model.
So I could go online and get CBTI.
Yeah, so there's some, and actually the evidence, there's a couple of platforms out there. There's some that have actually been tested using this gold standard randomized controlled trial and have found that it actually does reduce insomnia symptoms and has tracked people for a year or so. And so there's a couple of options, and they've been tested. That's the most important thing. There's a lot of options, but testing is very important.
So let's go back to language.
Yeah.
In addition to just translating, is there something else that has to happen with this? Because it's not just language, but culture. The way people understand certain things, it's quite different from culture to culture. Is that part of the challenge here?
Absolutely. So we've actually done some quantitative work on this. We've done some qualitative work where we've talked to people in focus groups. And what's emerging from both of these studies and this research is that acculturation stress among Latinos seems to be very important to experiences of insomnia. And enacculturation stress is the distress you experience as a result of integrating and adapting to a new culture.
So say something about that.
Yeah, this can be related to, sort of conflict associated, whether it's intergenerational conflict. So you moved to the U.S., you're trying to raise your children in the United States, or your children were born here. And I'm thinking sort of from a parental perspective, your children were born here, you weren't, you have certain cultural values, you're experiencing distress as a result of what it means to parent in a country that you weren't raised in. And so what we've learned actually from these studies is that seems to be an important factor, an important predictor, an important aspect of their insomnia experience that they identify both in quantitative work and in qualitative studies when we talk to people.
I just want to come back to this in a minute, but do want to remind everyone out there, you can ask questions if you'd like to. Just go to the comments section of your screen and put in your question, and we'll get an answer. Well, we'll try to get an answer.
Yes.
So you're talking about the kind of stress that somebody who has immigrated to this country experiences. Are there other forms of stress that particularly affect the Latinx? Is that the way to say that now? I'm back in the old days here.
No.
I thought I was advanced when I went from Hispanic to Latino. But
so
Latinx?
Latinx is sort of, I think, inclusive of all genders.
I understood the reason for it. I just was caught by surprise at some point. But are there other? So we've got the immigrants, and there's a stress there that I think is pretty clear, easy to understand. Any other forms of stress that?
Yeah, so we've, in other work, and I with colleagues and also others who are interested in this research area have also found that ethnic discrimination is actually associated with poor sleep, whether it be, I think, insomnia or insufficient sleep like we were talking about earlier. And so that's been documented not just among Latinx communities, but among other racial ethnic groups as well. And so there's evidence that unique sociocultural stressors and then more general kinds of chronic psychosocial stressors, that they both actually affect your sleep.
I want to come back to the other stressors, but what's the link from the experience of discrimination to poor sleep? Yeah. Is there some psychological connector in there?
So I think we're trying, I think that's also a great empirical question. And part of it, I don't think that we know. What has been sort of tested or theorized is that it might actually lead to vigilance, right? And so if you're experiencing,
that's interesting.
If you're having experiences of discrimination, it may lead to vigilance and also rumination. You might be ruminating about them at night, right? Trying to make sense of it. Oftentimes, with experiences of interpersonal ethnic discrimination, some might be overt, some might not be so overt. And what happens is that because of the ambiguity, you might be up at night thinking, well, was it discrimination? Was it not? And you can see how that just leads to this rumination cycle.
What about anger?
I think that's also...
Maybe I'm revealing too much about myself,
but
I often, my ruminations sometimes are really angry.
I think that might also be possible too, but it's a cognitive. You see what I mean?
Yeah.
I think what's proposed or speculated is that it's a cognitive process that's happening, that's keeping you up at night, and that's linking this specific kind of stressor with sleep.
So again, cognitive behavioral therapy might be helpful in addressing not the discrimination, which is a terrible problem in this society that people have to live with for the moment. They can fight against it politically, but you live with it. But addressing the psychological consequences of that could be useful. And then the other kind of stress you were talking about are more basic, and I've assumed connect with being of lower socioeconomic status, to use jargon. That is to say, people who are poor and have to work 3 jobs have a lot more stress than people who don't have to work any jobs, maybe.
And this is, I think, when I think about interventions and structural sort of issues where it becomes really tough, right? Because, I talked in the beginning about there are these cultural beliefs that shape whether you think sleep is a necessity or sleep is a luxury. But the reality is that you could have a belief that sleep is absolutely a necessity, but you're living under conditions of poverty.
Right.
And you have to commute in New York City
Right.
for, an hour and 15 minutes to get to your job, and your start time for your job is 7:30 or 8 a.m. And so I think in that context, thinking about envisioning how you take these gold standard adapted interventions and adapt them in such a way that they could work for someone who has the belief that it is a drive, that it is a necessity, but then they also are living under conditions of poverty.
So
I
how
think
do
that
you
becomes a challenge.
do that? I mean, that's really tough.
I know it's really tough, and it's an area that I'm really interested in.
Yeah.
And when I do some of these community health fairs and participate, one of the I sort of talk with the participants who come, and we do insomnia screenings with team members of the Sleep, Mind, and Health Research Program that work with me. And one of the ways that I try to incentivize them to sleep better is by actually talking about their sort of the intergenerational links, talking about their next generation, their children, because even if they for themselves feel like, well, I can't,
It's hopeless.
then they sort of start, when I begin to engage in discussions about, well, what about, sometimes they might come to the sort of screening table, the health fair, and have, their children with them, and I'll talk with them about, well, what is it, what about the effect, how about your child? How many hours of sleep is your child getting? And, do you know that actually how you sleep affects their sleep as well? And sort of begin a conversation. And so I think that might be an entry point actually to sort of start that discussion of about what aspects can or can't change that might promote better sleep.
That's really interesting.
Yeah.
You earlier you used the word despair to characterize how people who have difficulty sleeping feel, which is a very strong word. And what it triggered in my mind is, I don't know if you're familiar with the deaths of despair literature, which has emerged over recent years.
No.
So very quickly, life expectancy in the United States is down over the last 3 years, and two sociologists at Princeton, Ann Case and Agnes Deaton, have done research to try to figure out why it's coming down. And they identified a population of people who are dying from suicide, drug overdoses, and alcohol-related disease. And they refer to these as deaths of despair. They're heavily focused among working class people. It happens to be a white, male, working class population where these death rates are rising quite dramatically. So I was just, this kind of social hopelessness, I don't know if social is the right word, it's a mix of economic and social, has a devastating impact on some people. And does that influence sleep? And
I think that's a great question as well. I don't think they've done. You can sort of speculate that it would, but I don't think we've actually have any of those studies that are doing that yet.
Well, we have 2 minutes left, and somebody would like you to comment on the Hispanic paradox, which is something that could take, I think, several hours rather than 2 minutes. Do you want to say something very quickly?
Yeah, so I guess I'll say a couple things. I think one is that actually there's been some work that has looked at sleep differences across racial and ethnic groups and has actually found that the more consistent finding is that among racial ethnic minorities, so specifically African Americans, Chinese, Latinx communities, that they are more likely to report short sleep, sleeping less than 7 hours, sleeping less than 6 hours in comparison to non-Latino whites. And so that's been pretty consistent finding. There's some inconsistency when you start to look at those different dimensions of sleep that I talked about in the beginning. One important thing that I do want to mention that's related to that question is that there's a lot of within-group differences. And so among the Latinx community specifically, we actually find, for example, that immigrants actually, despite their lower socioeconomic status, their sleep profiles are actually better than Latinos who were born here in the United States. And so that gets to the Hispanic paradox. It's important to know we see it with other health conditions, and sleep, actually, you can add that to the list.
I would love to discuss this.
Yeah, we'll have to.
And I would love, maybe we can come back again and have a real a real discussion about this.
Yeah.
So I'm being told we have another question, and we've got 10 seconds.
Yeah.
I'm a senior on Medicare. My sleep habits are poor, and I still work late hours in my private practice. Where and how can I get access to CBT outside of my current therapy?
Yeah, so this is part of it, and I appreciate that your question is, I want this kind of treatment. I think that's excellent, that sort of your incentive to get it. The big issue is that really in terms of finding qualified providers who can deliver this type of treatment, that's where we have the supply and demand issue. There are some providers here in the New York City who provide CBTI in English, and if you follow up with me directly, you can go to my send me a tweet on @Alcántara PhD, and I'm happy to send you some of the resources. But with my team members,
so let's give that address again.
Oh, it's if on Twitter, it's at Alcántara, ALCANTARA PhD, and you can message me, and I can send you that information.
So you can pursue this and other questions
Right.
through Twitter.
Yeah.
Another modern development that has passed me by somehow. I want to thank you for joining us today. It's been a pleasure talking with you, and I hope you'll come back at some point, and maybe we can pursue some of these questions further. And next week we'll be back, but we'll be back on Tuesday. So for those of you who've gotten used to Wednesday, it's changed. We're now going to be on Tuesday, and we'll be talking with Professor Neeraj Kaushal again about immigration. We spoke with her a couple of weeks ago, had a very interesting conversation, and we're going to be joined by a Columbia student, Bethany Miller, who's going to be going down to the border over the winter vacation to try to be helpful to the people on the caravan who are suffering out there. Hope you will see us next week. Thank you.
Yeah.